Good evening, everyone, and welcome to our live Q&A session on health-related quality of life for people living with HIV. My name is Jeffrey Hirono, and I am HIV Scotland's Policy and Research Lead. Before we start, some housekeeping. I will be moderating today's session, and I'll do my best to ensure that we remain within the allotted time frame, which is approximately 1 hour. Should anyone have any questions, please feel free to comment on the social media platform you are viewing the session from, and I will do my best to feed them to our panel. We will also be recording today's Q&A session, so if you do experience any technical difficulties, we will have the recording up on our HIV Scotland website and our YouTube channel within the week. So today, I am very pleased to present an exciting lineup of guest speakers. I'd like to introduce Dr. Megan Call, who is a lead epidemiologist at the National HIV Surveillance Team at Public Health England, and she is also the lead for the Positive Voices Surveillance Program, which is a nationally representative HIV patient survey which aims to understand the experiences and the needs of people living with HIV in the UK. Next, we have Dr. Jeffrey Lazarus, Associate Research Professor at the Barcelona Institute for Global Health and at the Hospital Clinic at the University of Barcelona, where he leads the Health Systems Research Group. He is also co-chair of the HIV Outcomes Coalition on the steering committee of the European Commission's Joint Action on Infectious Diseases. And finally, our third guest is Dr. Nicoleta Polychek, an associate professor in policing and criminology and the head of the graduate school at the University of Cumbria in the UK. Nicoleta is also chair of HIV Scotland's Board of Trustees, and she specializes in human rights legislation, human rights violations, migration studies, gender and sexuality studies, sex work, HIV/AIDS and public health, social impact epidemics, and emergencies. So I'd like to thank our panel for taking the time out of their busy schedules for being here with us today. Thank you very much. Before we start, I'd like to take about 5 minutes to give a brief overview of why we are conducting today's live Q&A. So our Living Well 50+ seminar series and briefings, including this live Q&A session, were made possible thanks to the funding from Gilead Sciences and the Henry Duncan Grants, which is managed by the Cora Foundation. So this Q&A session forms part of the Living Well 50+ initiative, which aims to deliver forward-thinking solutions to the challenges people living with HIV experience. So Scotland has achieved some great milestones. We've exceeded the global UNA's 90-90-90 targets. That means that of the 6,122 people living with HIV in Scotland today, 92% have been diagnosed. 98% of people diagnosed are now receiving HIV treatment, and 95% of those on treatment have achieved viral suppression. This is an incredible achievement. But at the beginning of the HIV epidemic, Scotland has had to focus on the science side of things. This was necessary at the time, but now that treatment has advanced so much, we can now shift our focus and begin discussions around what quality of life means for people living with HIV. So we know that health-related quality of life is central to the care and support of people living with HIV. And although we do have effective treatment to ensure people living with HIV live a long and healthy life, attaining and maintaining a better quality of life remains a challenge for many people. So a big question is, what do we mean by health-related quality of life? So in order to help answer this question, we hosted a series of seminars and invited people living with HIV, NHS and health representatives, academics, and public and third sector organizations, and asked them what quality of life meant to them and what were the main issues in improving quality of life among people living with HIV. I don't want to go too deep into this, since we'll discuss it later on, but based on the discussions we had, the major concerns were firstly about managing multiple health concerns and the negative effects of taking multiple medications. Secondly, many people living with HIV in Scotland experience mental health issues, such as depression and anxiety, which can have a negative impact on health-seeking behaviors and quality of life. And finally, societal concerns can affect the mental and physical health of people living with HIV. Some examples could be like insecurities around employment, financial insecurities, the experiences of HIV-related stigma, and the experiences of social isolation and loneliness. So all of these together represent some of the major contributing factors that lead to a lower health-related quality of life for many people living with HIV. So the next big question is, what can we do to ensure that people living with HIV have a better health-related quality of life? So without further ado, I'm going to bring in Megan to set the scene and discuss the Positive Voices survey that she leads on, and then we will open it up to the panel for discussion. So the first question, Megan, can you tell us a little bit about the Positive Voices survey?
Yeah, so thanks so much for inviting me on to talk today, and actually come back a bit to the HIV world after being spent quite a lot of time on COVID work. So it's really great to be able to talk to you all here today and come back to my first love, which is Positive Voices survey. So the Positive Voices survey is a nationally representative HIV survey of people living with HIV, accessing services. The first national round of the survey ran in 2017, and it ran in 73 clinics around, across England and Wales, and it recruited about 4,500 people living with HIV. And it was in a large omnibus-style survey, covered quite a few different topics relevant to the lives and experiences with people with HIV, but it did ask a number of questions around quality of life. Here's probably a good point to say that measuring quality of life is not simple. Quality of life is highly subjective. It's a very broad concept, and it covers any number of areas of one's life. So to that end, we actually have a number of different tools that we can use to measure quality of life that have been validated in a number of different populations. And some are generic, so they are for use in the wider general population, and some are HIV specific. In the Positive Voices survey, we used a couple of generic tools. So one was the EQ5D5L, and you may know this as EuroQoL. And this tool asks 5 questions around different aspects of life. So it asks around mobility, self-care like washing and dressing, ability to do usual activities, pain and discomfort, and anxiety and depression. And what's really useful about this tool is that not only can you measure individual different areas where people might be having issues, but you can use these different responses to create an index or a score at the end, where you can then give on a scale of 0 to 1 how good or bad is your quality of life. And then, of course, we can compare that to the general population. So briefly, what we found when we ran the survey is that people with HIV had a slightly poor quality of life compared to the general population. And why was this interesting to us? Because firstly, the population of people living with HIV is overall younger than the general population. So many of those domains ask questions around mobility and self-care. And those might be things that people who are elderly might have more issues with. And we were seeing similar rates around people living with HIV. The other thing that was really interesting when we looked at that was the rates of people reporting symptoms of pain and discomfort and anxiety and depression. When we looked at pain and discomfort, we saw significantly higher levels of symptoms among people with HIV. And this was the same even after you did control for age in an analysis. And we saw also higher rates among women, and we saw higher rates among people of Black and minority ethnicity. And we saw some geographical variation as well. And to the point of anxiety and depression, that was the area where the most symptoms were seen, actually. So we saw twice the rate of anxiety and depression in people with HIV compared to the general population. And that was higher as well. You may ask, How does that compare to people with other chronic diseases? People like with diabetes or COPD and things like that. And it was higher than most any other groups. And this is interesting because, of course, we know that HIV is a social disease, and it has many implications on one's social life, one's ability to function, and one's outlook on the future, even where the virus is controlled. So that's a kind of a brief overview of what we found with regards to the quality of life. Happy to take any questions on that.
That's fantastic, Megan. Thank you very much. That's a really great overview of the Positive Voices survey. I have a quick question from an audience that says that what impact has your findings made in improving quality of life among people living with HIV? You did mention that, for example, HIV being a social disease. Has there been any collaboration between like the third sector and the public sector and trying to implement any sort of interventions to address quality of life?
Well, I think that's a fantastic question. As we know, it's one thing to gather the information, but then what do you do with that, and how can you enact some intervention or some strategies and programs to try to improve quality of life? And that's actually a really tricky thing to do, because, as I said, it's very subjective for many people. I know, and I'm going to be part of a study in England that's happening over the next couple of years. That's going to be looking at taking things like health coaches, or you might call link workers. There's kind of different terms, the primary aim of this study is to improve quality of life among people with HIV. And so what that study will do is, first of all, screen people to find out what things are important to them, what issues there are, where is their unmet need. And then secondly, refer people into services or perhaps directly provide services that can help to improve quality of life with people with HIV. Now, that's going to be a randomized control trial. That's going to take several years to actually get the results from. But I don't think we need to wait for that to happen. I think there's a lot of practical solutions that can be done here and now. Services that are being provided by many of the third sector organizations and even clinics and GPs themselves. But perhaps they just need to become more accessible and more available to people with HIV when they need them.
Awesome. That's fantastic that there is ongoing research that's happening, especially in England and the UK in general. So we recently did our own kind of health-related quality of life survey, very briefly, just to kind of touch upon some of the major contributing factors that affect quality of life among people living with HIV. And I think it complements, if not, it essentially mirrors what the Positive Voices survey says. I'd like to talk a little bit about mental health, because obviously mental health is a major barrier for people living with HIV as it relates to health. So health-seeking behaviors can be a major barrier. So are there any kind of specifically regarding depression and anxiety, is it a priority area for people living with HIV based on the Positive Voices survey? And is there any sort of interventions that have proven successful?
So again, another great question. I think one of the key findings that really stuck out from the survey analysis was how closely associated loneliness and isolation was with mental health. And I've actually come to HIV Scotland to present some of these results last year. But it is really striking, the sort of linear correlation. So the worse the sort of experiences with loneliness and isolation, the worse the quality of life as well. So it's all interlinked. So I think I may not be the one to be able to talk about mental health interventions, so I'm not a clinician, but I think that there are obviously mental health resources and programs are available. It's perhaps whether or not they are being targeted in the right way for people with HIV and able to meet the needs. For example, sometimes loneliness and isolation, that the feelings can happen sort of right after the point of diagnosis. So it's very, very strongly correlated with the point of the diagnosis. And maybe you need something there directly when people have a diagnosis, a resource immediately available. And sometimes it's a wider need, and perhaps people having issues with disclosure or having been rejected in different ways by different people in one's life. And so I think there's many different ways that that can manifest. But I think if we were to address this issue of loneliness and isolation, I think that could go a long way towards improving quality of life and mental health symptoms.
That's great, Megan. So I was just informed by Dr. Jeffrey Lazarus and Megan about their involvement with each other as far as like their Integrate Patient Experience Survey. Dr. Lazarus, would you mind speaking a little bit towards it?
Sure, thank you. Yes, thanks for qualifying our involvement with each other, focused on the Patient Experience Survey. This is a European Commission funded joint action that brings together around 20 EU countries to address a range of issues around infectious diseases. It's called Integrate, and it's about how we can better integrate the services related to sexually transmitted infections, tuberculosis, viral hepatitis, and HIV principally. And Megan and I led a small piece of this work that was focused on the patient experience with HIV and with viral hepatitis. We wanted to look at patient-reported outcomes using EuroQoL, which Megan just mentioned and that she had experience with from the Positive Voices work. We wanted to use a new patient-reported outcome measure for viral hepatitis. And because it's a joint action, the participating country partners decide what they want to be involved in. So in this case, Romania, Croatia, and a part of Spain, Navarra, decided to be involved. And we surveyed the patients, the clients, the participants, I should say, with a combined, rather long survey of the EQ5D5L, EuroQoL, and PostQoL from Graham Brown's group in Australia, and a bunch of socio-demographic questions in order to try and really understand. One, the good thing with EuroQoL is you can often compare it to the general population and to other countries, and then to use a more HIV-specific tool around PostQoL. And maybe, Megan, since you just finished writing up the results, I'll let you just say a sneak preview into some of our findings from Romania and Spain.
Yeah, sure. So I think, again, just to reiterate, what was unique is that we used the generic tool that you can use in any population. Then we also used an HIV-specific tool, which was developed that hopefully would provide some further insights. And I think a couple key things that stood out was that anxiety and depression, so mental health symptoms, again, emerged as the main really predictor around poor quality of life in Spain and Romania for people with HIV. So very much mirroring what we've seen in England and Wales and what you've seen here in Scotland as well. So it's becoming sort of maybe a universal, at least in Europe so far. And some of the other things we found really were when you looked at the HIV-specific tool, PostQoL, that looked at different, we call them subscales, but different areas that people might find problematic. And the main area that came forward was health concerns. And that was really interesting to us because all the people, pretty much all the people, like 98% of those who took part were on treatment, virally suppressed, adherent to the treatment. Some, of course, did have comorbidities, but actually lower rates than what we see in the UK. And actually, the median age in Romania was 32. So it was a young population. And I think the conclusion that we could draw from that is people's fears about perhaps their future health, can maybe not their present health, but what their health might look like in the future and down the road, and how HIV might play a role in disease progression, and how long they can live, and how long they can live healthy and fulfilling lives.
Great.
Amazing. So there's quite a lot of research that's happening globally and again in the UK. So that's fantastic. Thank you very much. So based on these two surveys, so what is the overall outcome that, like, what's the next step now that we have this data? What are we expecting to happen?
I mean, I'll take a shot. I mean, I think we're expecting two main things. One, to share the results, not just with other researchers and community groups and affected populations, but also with policymakers, so concrete action can be taken to address those concerns. Also, I mean, this has been carried out in the UK, in Croatia, in Spain, and of course, a few other European countries. We hope that this will become European-wide. We want to see part of the European Commission, the ECDC's monitoring, take HRQOL for people living with HIV seriously, so that all countries are requested to survey their population of people living with HIV on a regular basis, so we can understand what the differences are between countries, and what are the actions that can best be taken, so we can address this also on a European-wide level rather than just every country on their own. So it's really about action-oriented research and the need for additional research.
That's great. So it actually is a perfect segue into the next section, because so at HIV Scotland, we want to embed a national health-related quality of life target into Scotland's HIV response. And given that we've already exceeded the HIV 90-90-90 target, what comes after the last 90? So where 90% of people living with HIV achieve viral suppression. Can you talk a little bit towards that, Jeffrey?
Sure. I mean, well, what comes next? Well, 95, 95, 95 comes next. And then at some point it will become difficult to reach 100, but that will always be the goal. But let me just scroll back briefly to 2005, when I was working at the HIV program in the World Health Organization. So back then, we were incredibly excited that antiretroviral therapy was being rolled out. We were working quite a bit with Eastern Europe. More countries were getting access to ART. And we started hearing from certain populations that they were really concerned about their comorbidities, and particularly viral hepatitis. We're looking at people who had injected drugs in the past, or were current injectors, and now they were on antiretroviral therapy, but what about their hepatitis C? So one of the big concerns, 10, 15 years ago were other comorbidities, like other bloodborne viruses, as well as still tuberculosis. Then if we move forward to 2015, UNAIDS had announced their 390s targets that you're all well aware of, and WHO was developing its 2016 to 2020 global health sector strategy for HIV, and they were going to incorporate the 390s into that strategy. And working with community groups like the European AIDS Treatment Group and members of AIDS Action Europe, we started discussing that, well, it was admirable and fantastic to be able to talk about reaching the third 90, that so many people would have virally suppressed HIV. But the new concerns that you're raising started coming out. Well, what about other issues related to health-related quality of life? What about the pain, the anxiety that Megan mentioned, symptoms like fatigue, insomnia, stomach pain? What about everything else that went beyond just this narrow focus on the virus? And we were privileged to be able to think this way in Western Europe, because so many countries were and still are far away from achieving the 390s in primarily low-income settings, but also some populations in middle and high-income countries. So there we got the idea simply to say, what about a fourth 90? And we'll call this fourth 90 health-related quality of life. And that was the paper a group of us wrote in 2016, basically talking about the new frontier in HIV that would put a focus on health-related quality of life. Later, it came out, there was a surprising amount of interest, and then the question that you raised came up, well, how do we measure that? And one group largely took a clinical perspective and said, well, we measure this by looking at the person living with HIV's comorbidity issues. If they really don't have comorbidities and they're doing well on ART, then they have a good health-related quality of life. But the community was saying it's not all about those established comorbidities, those conditions listed in the International Classification of Diseases. It's about a whole range of issues that only we can really tell you about. So we realized we also had to look at self-perceived health-related quality of life, the kinds of tools Megan was mentioning, like EuroQoL, the recently developed POSQoL, WHO surveys, and others related to patient-reported outcomes. So we stood there sort of with these two issues. So it wasn't as simple as the 390s, which are pretty easy to remember, with the last being 90% of people living with HIV are virally suppressed. We suddenly said, well, it's 90% of what? How do we assess that 90% of people have, or people living with HIV have good health-related quality of life? And I think we also made another mistake when we launched the fourth 90, because we were very focused on the HRQOL of people who were virally suppressed. And the community quickly spoke up and said, it's really about good HRQOL for everyone living with HIV. So we've rectified that in recent papers and in discussions over the last couple of years. The fourth 90 is good health-related quality of life for everyone living with HIV. Now the challenge is how to measure it, and we're in discussions with experts around the world. We're working on a consensus statement. What tool would we use to assess the self-perceived HRQOL of people living with HIV, and what comorbidities would we want to monitor? So I think, Jeff, if HIV Scotland turns to your surveillance agency, they'll say, not another indicator, not something more for us to do. We already have so many indicators. You need to be very careful in what you select and what you ask them to take on. We've been working with the ECDC, who incorporated a few years ago the very simple question of, they work at the country level, and it was, does your country you report on the health-related quality of life of people living with HIV? Just a handful of countries reported yes, and then there were two follow-on questions. If that was yes, well, which tool did they use? How often did they do it? And when was the last time they did it? So we're really calling for, in the first instance, all countries to regularly monitor the HRQOL of people living with HIV. Megan led a really nice study in Lancet HIV at the end of last year, reviewing all of the patient-reported outcome tools. And we'll be hoping to get some consensus on recommendations for the minimum. So a short, easy to use tool that can be translated into many different languages. And then also a list of the key comorbidities that health systems are reporting on in terms of people living with HIV.
Wow, that's fascinating. I really enjoy hearing that instead of tagging along that last 90 just after viral suppression, is actually throughout the HIV continuum. So people diagnosed, people on treatment, and people who are virally suppressed. So it kind of encapsulates all people. So thank you. Nicoletta, I'm wondering if you can add, I'm wondering how, in your opinion, how are health systems needing to adapt or expand in order to ensure health-related quality of life is addressed, in your own opinion?
In my own opinion, as someone living with HIV, I think that has something very easy to do, which is really listening in a very broad, simple way, nothing else. I've been hearing a lot, not just today, and I'm really grateful for the amazing work that you guys have been doing. But I think that when you talk about surveys, when you talk about huge cohort of people, there is less space to actually hear the different voices of people who are living with HIV. So that would be something quite simple and almost simplistic to do. If you're asking me the same question as an academic, someone who does research, then again, I think that we should have more space for different methodologies. And again, including those who are living with HIV from different diverse communities into the setting of the research from the very beginning, not including them halfway through.
Yeah, I completely agree. I think it's important to ensure that people are involved like throughout the monitoring and evaluation of any sort of intervention or program. Dr. Lazarus and Megan, perhaps you can comment on how, like, what role do you think health systems play in ensuring health-related quality of life?
Well, I think, I mean, if I may, Megan, I think health systems are essential, but I would take in the broad understanding of health systems. So this includes, social welfare issues as well, and really goes back to the WHO definition. And that's what I think the fourth 90 is about. It's going beyond, the absence of infirmity or disease and focusing on not just physical, but also mental and social well-being. And so it's challenging for health systems because mental health may be affected by loss of a job, the current pandemic situation, all of the angst that comes in this current situation, but that also comes along in life, and that the health system can't always address. So from the health system perspective, we always have to think, well, what can we do? But again, if I think about the Integrate project, not just the focus on infectious diseases, but how can we integrate systems better? We see some health systems work very well with their social welfare agencies, and some don't at all. So I think a key first step is to get, social care and healthcare joined up. And then also, I mean, as you said, Nicoletta, it's really about listening to the people as well. I mean, something that Megan's done at a huge scale, across the UK. But, like you said, it's not just the surveys, it's also the opportunity to tell individual stories, to have focus groups with groups that can discuss and bring out key themes and issues. But again, the health system is a tough machine to reorient. It's a big ship when it's set a sail. How do you move it in a different direction? And so we really need a top-down approach where we get the European Commission and its agencies like the ECDC and the EMCDDA to call on countries to address these issues, and a bottom-up approach that starts with the community, people living with HIV, alliances with researchers, individual champions, and organizational champions like HIV Scotland.
Yeah, I completely agree. I think, like you say, it is a large ship to right. So the health systems itself is a major thing that we just need to figure out, like how to write it into a way that we can actually improve the health-related quality of life. We have a question from an audience member. He's asking, I'm just going to read this kind of verbatim. How do we account for the different cultural environment? So, Nicoletta, perhaps this is something that you can comment on.
Yeah, thank you for this question. It's a very good question because the key point is exactly that we need to take into account different cultural environments. And the old model of aging well with HIV is a very sort of white, middle class, very much male, that we kind of try to adopt and adapt to. So we really need to kind of, the point that was raised earlier is about engaging into different discourses, everyone who does speak, not just a different language, which is the reality if we are referring to Scotland, but to many other European countries, but also the life and the lived experience of living with HIV, which is completely different. There are different cultural and intellectual settings within which we all live. And I'm talking about someone living with HIV. But there is another point that I'm particularly passionate about making, is that we need to make sure that I understand that researchers do have a job to do, but people with living with HIV also are able to do research. And rather than be consulted at the very last moment, we should be engaging from the very beginning of any research process. This is very important.
Yeah, I completely agree. One of the principles that HIV Scotland follows is that is involvement. It's a principle that we involve people living with HIV or at risk of HIV in every single step of the development of our programs or initiatives, like even going so far as saying like even to the monitoring and evaluation portion of any kind of intervention that we do. I'd like to move on to a different topic, is about measuring impact. And this is something that Megan, perhaps you can help out with. How do we measure what matters? Like, and what data should we be collecting and measuring that impact quality of life, and what does success look like?
That's a good question. I mean, I think we first of all, you need to find out what matters. So, and that comes very much back to Nicoletta's point at the start, is you have to ask people with HIV what matters to them. What are the issues that are concerning them? Where is their unmet need? And then you measure the impact after that. There's no sense measuring the impact on things. I think we've been focused for so long on biomedical interventions, and still biomedical interventions are the outcome measure of so many things that we do. How many people are on treatment? How many people are virally suppressed? What's the CD4 count? Doing different things with people with HIV. And I think it's really time that we moved, just in a very broad sense, completely reorient ourselves to thinking about other outcomes and these patient-reported outcomes. So again, just taking it back. I know researchers and politicians and public health people like myself like to have really concrete outcomes to grasp onto. But I think it's when you come to any chronic disease, but HIV in particular, where we have such a strong activist community, people who are very engaged and involved, then I think, you have to involve people with HIV in doing what's working. So it's kind of a bit of a broad answer. I think, from my point of view, and again, I'm not coming from like an individualistic sort of clinical point of view, but I would be looking more at the public health impact, the population level impact. And so I think that surveys like Positive Voices are a really effective way of measuring impact if you're measuring the right things, using the right tools, and sampling the right populations and making sure that everybody is included. But then I also would favor these mixed methods approaches where you're also actually asking people directly what's working for them, what's not, how the service can be improved, and what their needs are. So I think, again, a broad comment, because it's really measuring the impact really depends on what you're trying to change and how you're trying to change it. And I think then having all these tools in your arsenal of ways that you can measure these things, shouldn't have sat in front of a mirror, is ways to measure these things and picking the right tools for the right situation. I wonder if, I don't want to put Jeff in the hot seat, but I know that he's, like he was saying, he's working on trying to get these measurements maybe standardized, because there's no sort of gold standard at the moment for measuring health-related quality of life and other comorbidities. And so I think one of the key things is trying to get a consensus and a more standardized way of doing this. Yeah, absolutely. I think you hit it right on the nail.
one of the questions, maybe actually, Jeffrey, you might want to have the comment now that Megan kind of.
Sorry.
Sure. Thanks, Megan. Since you're a part of that group, it's I'm counting on you as well. But this is a global group of, I don't want to say experts, but yes, experts, and that includes Nicoletta, people living with HIV, who are trying to get a broad consensus on what we mean by this fourth 90, and in particular, how we're going to measure it. But I also wanted to mention another piece of work that we're doing in Spain together with Maria Jose Fuster, who is an active researcher living with HIV, and together with Kelly Seyfried Harman from my team, we're looking at developing a clinic screening tool. So doctors are very focused, and rightly so, that's their training, as I mentioned earlier, on specific diseases and specific measurable, more objective conditions. And what we're hearing from people living with HIV, and Maria Jose has really brought this to attention as the head of the president of CECIDA, the multidisciplinary research group for people living with HIV in Spain, was that there's all of these other issues that are more subjective, the pain and discomfort and insomnia and fatigue and angst and so on. So we ran a series of focus groups with people living with HIV to understand their priorities. And we also asked a range of clinicians and other healthcare professionals what they thought the main issues were. They're very different. So we will be publishing the clinician or healthcare provider perspective, the perspective of people living with HIV, and then we're working to mesh it all together. So we have a simple clinic screening tool. So when we tell doctors, you need to be addressing health-related quality of life, and they say, where do I start? Do I run a survey? How do I engage? This will kind of function as an icebreaker with a series of sort of 10 key conditions that the patient would fill out first, and then that would trigger or flag the healthcare professional to ask questions about that. How are you feeling today? You mentioned you haven't been sleeping well. What might be the reason for that? And they might need to make referrals because it's not their expertise as an infectious disease doctor, but it'll start to bring that conversation into the hospitals and into HIV care.
Yeah, I think that's really interesting about the standardization of capturing this kind of data, especially for healthcare professionals. I mean, healthcare professionals already lead quite busy lives, and they have like protocols that they have to follow. So how are you ensuring that, given that you said that they're being fed like prompts to ask certain questions, so given that health professionals lead busy lives, how are we ensuring that health professionals are supported in doing this kind of work and then capturing that data?
Well, I mean, the best way will be where community groups, where groups of people living with HIV can start to work with particular hospitals, clinics, or clinicians to pilot this in different settings and share those experiences. It would be nice if in a year from now we met again and we said, well, how did it go with X clinicians and X hospitals and clinics in Scotland, to try and change that conversation from, are you taking your medicine every day? I see your CD4 cell count is high and your viral load is suppressed. Here's a prescription for another 3 months or 6 months or however long your system prescribes for. It's very different across Europe. Instead, to be able to say, yeah, my doctor was asking me about how I was feeling. My doctor had brochures about housing assistance and employment issues and things that we don't normally discuss, but that for me are very important because I've been virally suppressed for a year or 5 years or 10 years, but I still have issues that need to be addressed. And like I said earlier, that's very much often in the realm of social care and not infectious disease department care. But if people living with HIV are still going to be seeing their infectious disease doctors, then I think we need to look at what Megan said, about reorienting services and thinking about new models of care moving forward.
Yeah, absolutely. So we have an audience question. I think part of it has already been answered by you, Jeffrey. How do we properly embed quality of life measurement into the health services? without it feeling like over-serving of people living with HIV? The first part was already answered by you, Jeffrey. So maybe Nicoletta, maybe the second part of that question, what are your thoughts about the feeling of over-serving of people living with HIV?
I think that I also think it's asking the right questions and focusing on issues that are really, because we tend to spend time asking questions about, feeling miserable and being miserable and suffering and pain. But, we never tend to ask questions about sex, sexuality, body shape, feeling. It's a bit of a trademark of mine when I talk about aging well with HIV, because I usually talk about sagging tits. And it's not just a funny way of engaging with the audience. It's a way of saying that I am a woman living with HIV, but first of all, I am a woman. I have sexual desire and sexual needs. And this is not the very first question that my HIV consultant is used to ask me, unless I train him to ask me this question. And then there are questions about women and menopause and our own relationship with blood. First, we had quite a lot of blood coming out of our bodies, and now there is no blood. And these are the kind of the important, and I don't want to be too sort of descriptive, because some people might find that quite intrusive, but these are the right questions about the quality of life, for instance.
Absolutely. I think it is necessary to see like the person, it has to be a person-centered approach as opposed to like seeing specifically HIV or like an HIV patient. So absolutely. We're going to move on to another theme, which is support and commitment from obviously the Scottish government. So hopefully I have a question for you, Nicoletta. In your opinion, what are some of the major obstacles in trying to implement, like, for example, the new HIV target, like the Force 90 throughout the HIV continuum? So what are the challenges that you see in Scotland?
In Scotland, apart from financial issues, which are issues that are faced within sort of the broad spectrum of the NHS, it's not peculiar to the HIV sector, but there is again one of the key obstacles for me is again there is not enough time to tailor-made care and social care to every single individual living with HIV. There is still the assumption that there is one sort of good behaving majority that are adhering to taking their medications, going to the gym and keeping fit, and it's putting quite a lot of responsibility onto us. And there is some sort of discourse still about failure if we don't obey to these preconceived ideas about aging well or living well with HIV. So I think it's about now is a good time, and we have opportunities to kind of feed into new discourses. And paradoxically, COVID has led the way, although it was unintentional, for patients' participation in different ways. There are more opportunities for voices to be raised, but also for the acknowledgement of voices that maybe don't need to be raised, but they just need to be acknowledged. And I'm talking about those who are never really involved. They're not talking publicly about living with HIV, but they do have HIV, and they're isolated geographically and emotionally and mentally isolated.
I agree. As far as the isolation, especially in Scotland, where many people living with HIV live in remote or rural settings with there are barriers in accessing HIV care, and that brings up other issues as well. I'm actually gonna put the same question out to Jeffrey and Megan. Jeffrey, if you'd like to go first, what are some of the obstacles in trying to implement a new HIV target like the Force 90? Like given your context?
Well, as I mentioned, there can be sort of sporadic efforts and pilot efforts, but I think we'll be most effective when it comes from the top. So we need to work our way up by getting hospitals to take this on, by getting the clinical societies, BIVA and others, EACS, the European Clinical Society, to adopt it, to get the Dublin Declaration monitoring system. That's the European HIV monitoring system, to expand the number of questions. So as governments are asked or even ordered, to do so, I mean, ordered by their policymakers, or who run the agencies, I think we'll start to see an effect. And at the same time, we shouldn't be waiting for that. We should start looking at what measurements can we do. It has to be simple. Whenever I travel and talk to the surveillance folks, they tell me, like I said earlier, I mean, one more thing to measure. Just give us an easy question, something where we can collect the data. And I always say, think about it in Scotland, and I don't know if either of you can answer or someone in the audience, but do we know what people living with HIV die of every year in Scotland? Do we know what the hospital admissions are for people living with HIV? And typically we don't. We often have cohort data, and very good, rigorous cohort data, but the systems aren't typically monitoring that. And so we need to get better at understanding even those basic questions that I think it's easy to sell to a politician, that we want to know what people living with HIV are dying of, which comorbidities, for example, and then make sure that we can start particularly targeting those, setting a benchmark, and measuring that over time.
You bring up an important point about measuring, surveilling, and capturing that kind of data. Like in Scotland, we have a pretty robust surveillance database of people living with HIV, but it needs to be more robust. It needs to capture more information about health-related quality of life, mortality, and such. But yeah, absolutely.
Is it a government-run database, or is it a cohort study? Do you know?
I'm not entirely sure, so I'm going to write this down and find out.
Yeah, you want to ask, because Switzerland has a great cohort that covers almost everyone living with HIV. But in many other countries, the cohorts might cover 5 or 10 or 15 or at the most 20%. And it will give us good, rigorous data that we can rely on, but it's not covering everyone, and therefore we can't answer those kinds of questions.
Don't quote me on this, but I do think it is based on like surveillance from like different clinics, and it all feeds into one database that our surveillance team in Scotland produce. Megan, same question. What are some of the challenges or obstacles in implementing a new HIV target, based on your own opinion?
Yeah, I mean, I think it's we start by changing hearts and minds, I guess, in deciding. People look at quality of life and other of these, any sort of patient reported outcome, and that can be just symptoms of depression, anxiety. That could be symptoms of pain. That could be resilience. It could be positive things as well. But anything like that has long been regarded as like a soft target or a soft data collection. And there's been some sort of strange reliance on these really hard, clinical or clinician reported or clinician judged outcomes. And so I think one big barrier has been just acknowledging that these things are important to measure. I mean, and Jeff has been talking about quite high level monitoring tools, but I think these are really important to pay attention to, even at the local level. So say UNAIDS has a list of, I think, 200 indicators that it thinks countries is important for them to monitor, and not a single one of them is something that has to be reported by a patient. Not one. So even in the inclusion of one of those things, one indicator is a big step forward. I think the funding is an issue, and where that kind of comes into play is, I mean, from personal experience working at Public Health England on the Positive Voices study, one of the key levers to make that even happen was the government white paper that set out, make sure I get this right, but I think it was the 5 domains of good healthcare delivery. And one of those domains, so there's things like safety and efficacy, and but one of those domains was ensuring that people have a good quality of life if they're living with long-term conditions. This was part of the NHS outcomes framework. And that was actually a mandated data collection in the NHS since 2011. Now, has it been happening across all, long-term conditions? Has it been taken up the way it should? Probably not. But at least when we say why this is important, we can say, well, look, the NHS white paper has said that quality of life is important. So please give us the money to run the survey, or, please, NHS Trust can say, please give us some money for a peer navigator or a social worker, because we have these needs. And in order to make sure that our patient cohort stays happy, healthy, and engaged in care, we need to address all these other social issues and all these other wider, more holistic issues. So it is sometimes about the high level levers that then endorse local action and local level change.
It makes absolute sense, Megan. You make a good point about money, like the funding to be able to provide these kind of like interventions, which brings me to, I'm mindful of our time. So just one last question to our panel. So in the sphere of money, so what is needed from our political leaders to ensure that quality of life is addressed? And are there any examples of what good political leadership looks like?
Anyone want to start on this vein?
Yeah, so like even a no answer is an answer. So like, yeah, so anybody can have a go at that question.
I mean, I jest because one of the things the new Spanish government did do was put one of the authors of the Fourth 90 paper in charge of the HIV strategy. And she immediately convened experts, largely people living with HIV from around the country, to meet inside the Ministry of Health a year ago, February 28th, and discuss what we could do with the Fourth 90. Obviously, things have been sidelined during this pandemic, but a good political leader can speak out on the issue, but they also might put the right people in the right place with some funding, to make change.
Excuse me. Yeah, absolutely. That's a great first step, though, to be able to put someone who has that kind of expertise into a position where they can actually advise. Excuse me, I drank water wrong. Advise on like health-related quality of life and implementing any sort of strategy for improving health-related quality of life throughout the continuum. So given that we only have a couple minutes, does anybody have anything they'd like to add?
I would just, in closing, say that, if we look ahead towards the Fourth 90, we might say there's so much to do. We're really just at the start of understanding what we mean by health-related quality of life for people living with HIV, understanding how to measure it, but we also need to look back a bit. And, to go back to your question about good political leadership, I mean, it's now at least, firmly established across, the European Union, and I'll say in the UK, the importance of diagnosing, linking to care, and treating people living with HIV. Because I think most of us can remember a time when that was not very high on the agenda. That was our greatest challenge. People were dying, of AIDS in huge numbers. And now we have this fortuitous opportunity to be thinking ahead. And we need to remember that around the world, not everyone has reached the first, second, or third 90. So while we're, working hard towards understanding and reaching the Fourth 90, we need to look also to continue that kind of solidarity that's been so well known in the HIV movement with certain marginalized populations across Europe, but also many lower income countries around the world who are still far off meeting that UNAIDS WHO target.
Anybody else?
I think just to go off of what Jeff said, I just think though that what we're doing in developed countries where we have met the target can be seen as a template that other countries over time will be able to adopt. So to not be looking ahead now, in many cases with aging populations, and with a lot of question marks still about what it means to grow old with HIV, have HIV for your entire life and be on treatment for your entire life, I think this is the opportunity now to be looking forward beyond the point of viral suppression and look at these other wider outcomes.
Yeah.
We don't want to reinvent something. If there was a standard guideline on implement health-related quality of life, would be fantastic. And like a country like Scotland could actually implement as well. Would be good.
Yeah.
Okay.
Yeah.
Fantastic. So I think that is us. This brings our health-related quality of life to a close. So we are fortunate to have a wide range of speakers today, and I want to thank our amazing panel for their willingness to share their time and expertise with us today. Thank you very much. I would also like to thank Gilead Sciences, the Henry Duncan Grant, and the Core Foundation for allowing this kind of important work to continue and to help keep health-related quality of life a priority agenda item. And finally, I'd like to also thank our audience for taking time this evening to view and ask questions of our panel. This is incredibly important, as it is our collective efforts that we will see the HIV response advance in the coming months and years. This session is recorded and it will be on our website soon. So hopefully within the next week.
Thank you. Thanks for having us.
Thank
you
you.
very much, everybody. Really appreciate it.
Thank you.
Keep
Thank
up
you
the
very
good
much.
work. Thanks.
Thank you.